Occupational dermatoses, a clinical perspective. Introduction. Imagine a worker stepping into their workplace every day, unknowingly facing invisible threats to their skin. Occupational dermatoses are among the most common occupational diseases, accounting for nearly 30% of work-related illnesses. These conditions, caused, aggravated, or exacerbated by workplace exposures, do not just affect the skin, they impact the quality of life, productivity, and even livelihood of those affected, from irritant and allergic contact dermatitis to occupational acne, pigmentary disorders, and infections. Occupational dermatoses represent a broad spectrum of challenges. As dermatologists, understanding these conditions from their etiology to management is essential in delivering precise, effective care. Etiology. The causes of occupational dermatoses are as diverse as the workplaces they originate from. Chemical exposures, irritants like acids, alkalis, solvents, detergents, and oxidizing agents wreak havoc on the skin barrier. Allergens, including nickel, chromium, rubber additives, dyes, epoxy resins, and formaldehyde, lead to immune-driven reactions. Physical factors. Friction, repetitive trauma, and extreme temperatures, whether from frostbite or burns, damage the skin. UV and ionizing radiation are occupational hazards in outdoor or industrial settings. Biological factors. Workplace contamination exposes individuals to bacteria, fungi, or viruses. Plant or animal allergens in agricultural and veterinary professions add another layer of risk. Mechanical factors. Prolonged use of personal protective equipment, PPE, creates occlusion and friction, contributing to skin irritation. Individual susceptibility. Pre-existing conditions like atopic dermatitis or psoriasis, along with genetic predispositions, heighten vulnerability. History. A detailed history is the cornerstone of diagnosis. Onset and symptoms. Did the symptoms develop suddenly or gradually? Workers may describe itching, burning, or discomfort in affected areas. Exposure details. What chemicals, tools, or equipment are they handling? Are they using PPE, and if so, how effectively? Temporal relationship. Do symptoms worsen during work hours and improve on weekends or vacations? Workplace factors. Evaluate the work environment for temperature extremes, humidity, or poor ventilation. Personal and family history. A history of atopy, psoriasis, or other conditions may predispose the individual to occupational dermatoses. Clinical findings. Occupational dermatoses manifest in various ways. Irritant contact dermatitis, ICD, in acute cases, erythema, swelling, vesiculation, and peeling dominate. Chronic cases present with thickened, fissured, and scaling skin, commonly on the hands or forearms. Allergic contact dermatitis, ACD, erythematous plaques with vesicles and oozing in acute stages. Chronic lesions often show lichenification and pigmentation changes. Occupational acne. Workers exposed to oils or dioxins may develop comedones, papules, or pustules. Pigmentary disorders. Hyperpigmentation from hydrocarbons or coal tar, and hypopigmentation from depigmenting agents like phenols, are common. Infections. Agricultural workers often encounter fungal infections, while poor hygiene in certain settings may lead to folliculitis or cellulitis. Other manifestations, urticaria, granulomas, and photodermatitis may occur depending on the specific exposure. How to diagnose? Diagnosis requires a structured approach. Clinical evaluation. Document lesion morphology and distribution, correlating findings with the patient's history. Patch testing, essential for identifying allergens in allergic contact dermatitis. Skin biopsy, useful in distinguishing between ICD, ACD, and other skin conditions. Photopatch testing, for photoallergic reactions. Combining light exposure with chemical testing. Microbial cultures, rule out secondary infections or occupationally acquired infections. Laboratory tests. Blood work can reveal eosinophilia, IgA levels, or autoimmune markers when systemic conditions are suspected. Workplace assessment. Collaboration with occupational health teams ensures accurate identification of hazards. Management. Effective management is built on prevention, treatment, and education. 1. Prevention, education. Teach workers about proper handling of chemicals and the importance of PPE, protective measures. Ensure access to gloves, barrier creams, and non-irritating soaps. Workplace modifications. Substitute hazardous materials, improve ventilation, and reduce humidity. 2. Pharmacologic treatments, topical therapies. Use potent corticosteroids like clobetasol propionate 0.05% for acute flares. Hydrocortisone 1% is suitable for mild cases. Calcineurin inhibitors like tacrolimus 0.1% offer steroid-sparing options. Systemic therapies, corticosteroids. Prednisolone 0.5 to 1 mg/kg/day for severe cases. Tapered over 2 to 4 weeks, antihistamines, cetirizine 10 mg per day or hydroxyzine 25 mg at night for itching. Immunosuppressants, azathioprine or methotrexate for chronic, refractory conditions. 3. Non-pharmacologic therapies, phototherapy. Narrowband UVB or PUVA is effective for chronic dermatitis, barrier repair. Emollients containing ceramides or urea rebuild the skin barrier. Stress management, address psychological contributors to dermatitis. Treatment algorithms, mild dermatitis, start with emollients and low-potency corticosteroids. Moderate dermatitis, add medium-potency corticosteroids or calcineurin inhibitors. Severe dermatitis, consider systemic corticosteroids, immunosuppressants, or phototherapy. Conclusion: occupational dermatoses challenge dermatologists to combine clinical skill with occupational insight. By accurately diagnosing and managing these conditions, we not only heal the skin but protect livelihoods and restore quality of life. This is the intersection of dermatology